Okay. Well, thanks for everybody who joined on such short notice. We are trying to pilot this project of having the PGY2s in pain and palliative care do what I would consider to be relatively brief but core topics in the pain and palliative care area. Dr. Rea, who you probably see on the screen as well, is going to be our inaugural presenter. And until we get other people that are interested in jumping into this learning activity, has graciously agreed to keep the program going until we can get a little bit more buy-in. But for those of you who are on, I certainly appreciate you doing it on short notice. Dr. Rea is our very first PGY2 in pain and palliative care here in the Southern Illinois area, and I'll let him talk a little bit more about what he does, and then he'll launch off into ALS. Just as a quick side note, I probably have to disclose somehow that we are recording this webinar, so at the end during discussion, if you do not wish to have your voice recorded, please use the chat feature to ask questions or comment instead of the actual microphone. So with that, I'll mute and turn it over to Dr. Rea.
Hi, everyone. Thanks for coming. Right now, like Dr. Herndon said, I am a PGY2 pain and palliative care pharmacy resident in Belleville, Illinois. It's a brand new program where we're still trying to figure out the kinks about where I'm fitting in, but essentially what I'm doing is I'm going over patient charts and looking at all the new admissions. So I'm printing out those every day, and then I'm sitting in every IDG meeting to make recommendations to physicians and nurses. Another thing that's going to be big for me is educating patients. It's going to be nurse-based as figuring out who I'm going to go to educate on side effects and on medications, especially in patients that might not have the acuity to figure out what these medications do and might have additional questions that nurses might not be able to answer fully. With that, I will have different projects throughout the year, and I will have different settings like inpatient pain and things like that where I will be going out and doing, but my main facility is in hospice, and I am fully employed by Hospice of Southern Illinois. So without further ado, I will begin, and I am going to be talking about amyotrophic lateral sclerosis, or ALS, today. So essentially what ALS is when you look at it in Greek terms, it's essentially no muscle nourishment. So A means no in Greek, myo means muscle, and trophic means nourishment. Now it has gotten a lot more publicity lately with the whole ice bucket challenge that has come up about a year and a half ago, where the people were really trying to open up what ALS is and what we can do to help kind of treat it, because it is still something that is going to require a lot of research to figure out the best ways to treat it and how to kind of slow the progression of it. Another name you might know by is Lou Gehrig's disease. He was a famous baseball player that was diagnosed with ALS back in the day. So essentially what this disease is a progressive neurodegenerative disease of the brain and spinal cord that eventually leads to paralysis. Now with that paralysis, patients still do feel pain. It's not like they are unable to feel the pain. They just can't move their muscles and limbs. They can't breathe as easily. And I'll get into that a little bit more when we talk about side effects of this actual disease. So as far as the epidemiology of this disease, it's very rare. It's estimated about 2 per 100,000 patients, or about 1 diagnosis per 90 minutes. It's typically a disease that affects older people, so 55 to 65 years of age is typically when you are diagnosed with this disease. However, it can happen in younger years, such in your 20s and 30s. However, it is more rare. It is estimated that 15 to 20,000 patients are living with this disease. However, it's really hard to determine because with this disease, physicians are not required to report cases. So that number is more of an estimate than an actual number that we can determine. Another problem with actually figuring out how many people are living with this disease is that it's very hard to determine if patients have ALS, and that's because it's a diagnosis of exclusion. Really, there's no good biomarkers to determine if a patient has ALS. You essentially exclude other possible disorders that a patient could have that are similar to ALS, and then what you're left with is saying that the patient does have ALS. As far as who's most likely to have the disease, men are about 1.5 times more likely to develop this disease than women are. As far as ethnicities, whites are the most likely to develop the disease. They're about 2 times more likely than African Americans or Asians to develop the disease, and about 3 times more likely than Hispanics to develop the disease. As far as risk factors, it's hard to say because we really don't know how this disease starts. We know the kind of the pathophysiology of how it progresses, but we really don't know that initial factor that starts it. So we know gender and age are 2 things that are things that put you at risk. Other things, genetics do play a risk. There's 2 different types, which we'll talk about briefly, but genetics do have a role in the development of ALS. Outside of that, a lot of it's up to speculation. Environmental factors are potential. There have been clusters of ALS that have developed throughout the years, but there hasn't been a secure diagnosis of why these clusters have occurred. So it's still a lot of research figuring out how this disease process actually starts. There has been some studies to suggest that cigarette smoking increases your risk up to 2 times as likely. And then if you stop, like any other disease associated with cigarette smoking, your risk is supposed to go down. There has also been some data support lead exposure and military exposure to increase your risks of developing this disease, especially with the Guatemalan. There was a case, a cluster in Guatemala at the time when we were at war, or there was a war in Guatemala where there was a cluster in Guatemala associated with military, with the military. As far as the different types, which I was kind of talking about a little bit earlier, most cases we don't know why, and it's called sporadic, and it's in over 90% of cases. Patients just develop this. They don't have a family history of it. There's no really confounding variables to suggest that they're going to develop ALS. They just do. There are other types such as familial, which is rare, and it's an autosomal dominant. Now, SOD1 gene has been associated with the development. However, there are numerous other genes that have been associated with the development of this disorder. When thinking about the familial, if you do have a parent that does have the disease, the risk of it passing to the child is about 50%. So it is a somewhat of a risk if the parent does have the disease and it is classified as familial. Now, when you're looking at these 2 different types, really the risk factors, and not necessarily the risk factors, but the actual presentation of disease isn't different between these 2. It's really just more about how these patients undergo developing the disease that looks at the different types.
As of right now, that's what they'll keep.
So the pathophysiology, I'll get into this a little bit. I know I have a lot on the slide, but essentially what happens is there's a numerous amount of different reactions that have to occur to develop ALS. Now, how it initiates, it's not very well understood. We know that there's multiple factors that are potential, but we don't really know why the disease process starts. However, we do know kind of what happens once that disease process does start. Oxidative stress is one thing that does happen, and essentially what that is the buildup of free radicals in the central nervous system that can lead to this disorder of neurodegeneration. Also, we have misfolded proteins that can accumulate in the neurons. We have sodium channels that can become hyper-excitable. And then there's other different pathophysiologic mechanisms that do occur, such as mitochondrial dysfunction, growth factor deficiency, axonal transport abnormalities, and then caspase enzyme activity. Essentially, the caspase enzyme activity is something that leads to apoptotic or inflammatory pathways leading to nerve cell death. And that's kind of the end result of this disease, is that your nerve cells do die. And unfortunately, as we know, nerve cells aren't something that kind of regenerate very easily. So once that does occur, there's not a good way to actually regenerate those nerve cells. Something interesting about this disease is that typically in our body, in our central nervous system, we have astrocytes and microglia that kind of help our neurons to get rid of these toxic substances and kind of get them out of our neurons. However, they have found that these astrocytes and microglia, when patients do have ALS, kind of turn against the body, almost like an autoimmune disorder, where they start giving off toxic substances that damage themselves. So it's there's a multitude of different reactions that occur with the pathophysiology of this disorder to kind of lead to the development of ALS.
Yep, make that line and then it's good to go.
So as far as ALS goes, it affects both the upper motor neurons and lower motor neurons. So to be diagnosed with ALS, typically you will have both diagnoses of both upper and lower. If you only have one or the other, it's typically diagnosed as something else. So if it's just the upper motor neurons that have been degenerated, typically it's known as primary lateral sclerosis. And if it's just the lower motor neurons, it's what you're typically going to be called progressive muscular atrophy. And then as far as the progressive muscular atrophy, the primary lateral sclerosis, it's typically you only get diagnosed with that if you've had these symptoms for 4 years or longer. One thing that's unfortunate about this disease, or ALS, is typically patients don't even live that long. It typically takes about a year to diagnose these patients, and after diagnosis, the typical survival is 3 years or less. Now, 10% of patients do live a decade or longer, but that is only 1 out of 10 patients who actually live that long. Most patients after diagnosis live 3 years or less. So as I said earlier, this is a diagnosis of exclusion. So essentially when a patient, it typically presents with unilateral weakness in one of the limbs, which I'll talk about in a couple slides. But what they have to do is essentially they do a bunch of different studies and nerve studies, they do MRIs, they try to exclude everything else. So they do nerve conduction studies because essentially with this disorder, you don't have sensory loss in your neurons. You still have senses, you can still feel things. So what you're doing is if you do a nerve conduction study and start noticing that they have sensory loss, it's probably another disorder. As far as the brain and spinal MRI, this is to kind of exclude other things such as cervical spondylosis that might be occurring in these patients. So the diagnosis or the time of diagnosis is typically greater than 1 year, which is unfortunate because these patients, it's a terrible disorder. And when you're actually looking at this disorder, trying to tell a patient that they have ALS is a very hard thing to do. And it's really important if you ever have to tell someone that they are diagnosed with ALS, which typically is done by a physician, but it'd be important for them to have friends and family around because really after they're told, their likelihood of surviving over 3 years is very minimal. And with that, it's going to be not something like cancer where you can still function. You essentially lose your ability to walk, to talk, to breathe. You can't swallow saliva, so you're drooling. It's a very debilitating disorder that happens in these patients. So what are the manifestations of this disease? So really, like I said, it's typically unilateral limb weakness. So either weakness in your left hand, your right hand, your left foot. And that's typically the presenting factor. And that's about 65% of patients. This can include things like drop foot, difficulty walking, not being able to write appropriately. And that's what we would call limb onset ALS. Now, there is another type of ALS or another presentation of ALS, which is called bulbar onset ALS. And that's typically about 35% of the times. And that has to do with the muscles involved in speech and swallowing. So these patients present where they can't talk like they used to. They might not be able to swallow foods appropriately. They might start choking more often. Either way, the progression is typically similar, and when it starts, it will progressively get worse. So if you do have unilateral weakness as a presentation, it will eventually go to bilateral and then to all of your limbs, hands and feet, where you are wheelchair bound. Some other things that occur with this disease is cognitive dysfunction, and that's in about a quarter to a half of patients. And there's a few things that go into play with this. One of them is pseudobulbar affect, which is about 30 to 50% of patients actually develop this disease. And that's an inability to appropriately respond to stimulus. So if something funny happens, you might start crying, or something really sad happens, you might start laughing. And that's not that doesn't have to do with your personality. It has to do with actual changes from the disorder. And other things that can happen are anxiety and depression, and then dementia. So these are things to look out for. There's a multitude of symptoms, which I'll get into. But as far as the cognitive dysfunction goes, those are the main things. And one thing to realize is that this disorder typically starts off as painless. Pain can develop, and it can develop from neuronal damage. However, oftentimes it develops from things like bed sores, from not being able to move, from being bedbound, and things such as that. So treatment. Now, this is a disease that I would classify almost similarly to Alzheimer's as far as treatment goes, because for one thing, there's no cure right now. For another thing, there's really no good treatments. Really, there's one treatment right now that's been out for about 20 years. I'll talk about a little bit, but it only increases survival for 2 to 3 months and is an extraordinarily expensive medication. So really, this is a disease where you're trying to make patients comfortable. It's all about symptomatic support. It's all about making patients survive the best they can while they have time left. Now, there is a bunch of research going on trying to figure out, for one, how this disease is initiated, and for two, how we can actually treat this disease. And it's going to be important to try to protect those neurons, because right now we don't really have treatments to regenerate neurons. Now, there is stem cell research and other things going on about this disease, but I'm going to go over some of these symptomatic supports and how we can actually play a role in helping some of these patients through symptomatic support. So one thing is SIALORRHEA, which is essentially excessive drooling or salivation in the mouth that they can't excessively get rid of. And really the risk with that is aspiration pneumonia. So we do have medications that are used to treat it, and the data is varying, but really what we're going to use is cholinergic or anticholinergic medications to try to dry up those salivations or those salivary glands to prevent that from happening. Now you can see here I have some listed atropine, glycopyrrolate, scopolamine patches, and then TCAs. These are the ones that have been best studied. And if you're going to recommend these for these patients that might be developing or having these symptoms, it is important that these medications also have side effects within themselves. It's going to increase the risk for constipation. It's going to increase the risk for urinary retention. And one thing to realize about this disorder is patients don't typically lose function of their bowels and bladder. They typically do not become incontinent. So having urinary retention could be problematic in some of these patients. And then the cognitive dysfunction associated with these anticholinergics could be coupled with the actual cognitive dysfunction of the disease to compound with each other. Some other different medications that can be used is one thing is Botox. It actually does have good data. Now there's two different types of Botox that have been studied in this: Botox, botulinum toxin A, or botulinum toxin B. Now botulinum toxin B has more data to support that it is more beneficial than botulinum toxin A, and it is usually done by a neurologist in the neurology office. How this medication works as far as that goes is it inhibits the release of acetylcholine at the neuromuscular junctions within the saliva glands. So what that essentially does is it prevents saliva from being produced and prevents this disorder from worsening, or it actually reverses the disorder. Now, there is a small risk of inadvertent infiltration into adjacent muscles, so that is always something that patients should realize, but it does have some good data in preventing this in patients that can't be treated with the medications that I had listed previously. And then some other benefits you can see here. You don't really have the systemic side effects or the drug interactions that you would have with some of those other medications. And then the other thing that, and then other types of therapies, you can do portable suction devices to kind of get rid of that saliva. However, this is typically very uncomfortable for patients, so it's not something that patients typically like. Essentially putting a vacuum device in their mouth to kind of suck out the saliva. And not only that, it has to be done frequently. You're not treating really the cause of the problem, you're treating more of the effects of the cause. Some other things you can do is you can do radiation. You do risk dry mouth with that, and sometimes it typically lasts for about 3 months, so it may require multiple treatments. However, this can be beneficial, especially in some patients that are increased risk for aspiration or aspiration pneumonia. The last thing is a laryngectomy. It's not very often used. It really is only used if the secretion management can't be managed with anything else in patients whose speech is already compromised, because when this happens, you're essentially cutting off their speech. So really what you'd want to do is really assess individually, patient by patient, and typically this is not something that patients would actually undergo. So pseudobulbar affect, this is what I was talking about, where their emotions are kind of disconnected with how they should be feeling. There is an FDA-approved medication, dextromethorphan or quinidine or Nuedexta. And really, as I said earlier, this happens with about 20 to 50% of patients that have ALS. And how this works is the dextromethorphan has anti-glutamatergic and anti-NMDA actions, which has been shown to kind of help reduce or to reverse the effects of PDA. And then the quinidine, what that actually does is it helps decrease the breakdown of dextromethorphan. So it actually adds as a buffer to keep more of the dextromethorphan in the body, to keep levels higher. As you can see here, it's typically dosed as 20 milligrams dextromethorphan with 10 milligrams quinidine twice daily. So spasticity is another thing that often occurs with these, and it's often associated with upper motor neuron damage. And really what this is cramping or incoordination with the movements. And really, as far as data goes, we do know that muscle relaxers can help, but there's not a whole lot of good data to support one over the other. Typically, what we would use is baclofen. You can see the doses here up to 120 milligrams a day. And then tizanidine, you can use, it does have some data. However, it's typically used for refractory spasticity that really can't or hasn't been treated with the baclofen. Now, you can use intrathecal baclofen pumps, but that's really for refractory medical spasticity that can't be treated with PO options of these agents. Pain, as I said, these patients typically don't present with pain, but they can develop pain, and that pain can be due to neuronal damage, and it can also be due to the inability to move, so their inability to reposition themselves and they need to, the development of bed sores. So really the guidelines or what is recommended is non-opioids first line, but you know, a lot of patients aren't going to be adequately treated with that, and especially if they are at the ender stages of this disorder, opioids are going to be necessary, especially for quality of life improvement, since that's really what we're doing with these patients. We're not really worried about, or we're not really, right now, we're not worried about extending their life because they don't really have a whole lot of treatments to do that right now. Now, there are treatments in phase 2 trials, and there are treatments and studies that kind of look at agents that could potentially kind of prevent the progression of the disorder. But once those neurons are dead, we don't really have a whole lot of treatments to kind of bring them back to life, unfortunately. So now I'm going to go over some of the other kind of symptomatic supports that I talked about. Depression, there's not a whole lot of good data one way or the other to support one agent. Typically SSRIs are used, but there's not a whole lot of data to support this. So if you do give a patient an SSRI that has depression with this disorder, you might, and it's not working, you could always try an SNRI or TCA. You could try a different agent, especially if they are having some of these other symptoms like SIALORRHEA or this increased saliva. Head drop's another thing that happens because these patients do become paralyzed. They do lose the ability to hold their head up. And really pharmacologic treatment isn't necessary here because there's not a whole lot you can do. However, in the early stages, a lot of times you can use a soft collar to kind of help support their head, to kind of help hold it up. But as this disease progresses, a lot of times you will have to kind of move to a hard collar to help support their neck. Now, the shortness of breath can be treated sometimes with BiPAP. Sometimes they need to go into intubation. It really depends on the progression of the disease and where in the disease state they currently are. And then one of the things that is kind of important is communication. These patients lose their ability to talk. They lose their ability to communicate with their friends and their families and their caregivers, which is very problematic. So being prospective and trying to realizing that this is going to happen in these patients, it's important to come up with a plan of how they can communicate. Now, one of the things that has been developed in the more recent years is eye tracking software, which can help to communicate. There are other things that can become more personalized if they are still able to speak, to record their own voice, so they can communicate at least on a personal level with their own voice once they do lose their ability to speak. So the eye tracking software is something unique, which still keeps their ability to communicate in patients that do have this disease. Other than that, I will talk about the one medication that kind of has been around for about 20 years to slow the progression of this disease. And it is the only medication out right now that actually does slow the progression, but it only increases their survival by 2 to 3 months. Essentially how it works is it binds to the or blocks the sodium channels, which kind of helps to prevent damage from these neurons. It doesn't appear to bind to glutamate receptors. However, it is associated with anti-glutamatergic activity. It also prevents glutamate reuptake in the synapse and prevention of glutamate release in the presynaptic terminals. The problem with this medication is even with Medicare, it costs $2,000 to $3,000 per month for increasing your survival by 2 to 3 months. And really patients have to really figure out, is that worth it for them and their families to pay? Because these patients don't have a very good quality of life, unfortunately. They can't do a whole lot. They essentially become paralyzed, but they can still feel. They can still smell. They can still taste. They don't lose those functions. They still have their senses, but they've essentially become paralyzed. And then some of these other things with Riluzole that you have to realize is that there's a lot of side effects with these medications. It can increase difficulty with breathing, which is a big problem because these patients already have problems breathing. So what you can essentially do is put them into more distress by causing more problems breathing. It can also cause weakness, and it's important to realize that this can cause liver damage too. So if you are giving this medication, you would want to actually look to make sure they're not undergoing any kind of like jaundice or any noticeable liver damage situations. Now, fortunately, these patients, or I should say, unfortunately, these patients prognostically are not very well off. They do only live for, typically 3 years at most, at least 90% of the cases. So liver damage might be one of the last things you really worry about. Then to kind of end it off, there are quite a few medications that are on the rise. You can see there's some phase 1 study drugs with numbers and letters, which I'm not really going to get into, but there are quite a few phase 2 study drugs that are kind of looking at, are there agents out there? So you can see ozanezumab, it's a monoclonal antibody in phase 2 studies, which has shown some benefit in ventilatory compromised patients to kind of reduce that. Some other ones are Lunasen, which is a phase 2 trial drug, and it has shown to decrease progression of disease by as much as 50%. It was recently reported that a patient with ALS had dramatic objective improvement in speech, swallowing, limb strength while taking this medication. Other patients haven't had as good of luck, however, with the treatment options that we currently have. Something like this could be very beneficial for some patients. And as rasagiline, this is another medication that is thought to have some neuroprotective properties. So unfortunately, these medications coming out aren't going to cure the disease. Really what they're going to do is slow the progression. Really, we don't have a good handle on how we can actually stop or reverse this disease, since it does cause neuronal damage and neuronal death, which it's very hard to kind of come back from. So really the mechanisms that they're coming out with, trying to look at to improve patients with ALS, is looking at neuromuscular junction protection. They're looking at immune system modulating medications to reduce inflammation in these neuromuscular junctions and neurons to try to prevent progression of this disease. They're looking at stem cells to potentially shield motor neurons. And they're also looking at muscle boosters, which are essentially going to be used or thought to help making breathing easier and make muscles a little bit easier to move. And that's kind of my quick and dirty on ALS. So if you guys have any questions, please ask now. And thanks for listening.
So I'll start it off, since I bet people are quiet and shy. How many of these patients would you say you're seeing within Hospice of Southern Illinois? Is this a pretty large patient population for you guys?
Right now we have 3 patients that have ALS, and it's kind of, from what I haven't been here for terribly long, only a month and a half, but it seemed to come in waves where there'll be no ALS patients for months, and then there'll be a wave of them that come in. So right now there are 3 of them. I did get the opportunity to meet one. She was wheelchair bound. She could still move her head some, but you could tell the disease progressed pretty significantly in her, where she had very little motor function left in her.
I'd be interested to know, and I don't know this information. I don't know if you do either, Brad, but of anybody that's on the webinar, I wonder what the average length of stay. So I see on your slide prognosis, but I wonder what the average length of stay in a hospice program once they're referred is for a patient with ALS. Do you know, or does anyone on the call?
I personally don't know. And I really think that's going to be somewhat area specific too, because really it depends on at what stage they get introduced to hospice, whether it's at the beginning, in the middle of their stay, or near the end when they really need some help with supportive care. It really depends on at what stage they get referred to hospice, I would think.
I don't know if you're able to see the chat function, Brad. Dana wants to know how much the Ice Bucket Challenge raised for ALS, and I can't tell by the initials. But then we have what's the length of time for benefit with Riluzole?
So I am not sure about how much money the Ice Bucket Challenge raised. I didn't really look into that, but I do know a lot of it was more about getting people to realize what it was. It wasn't as much as, I know they want to raise money for it, but it seemed like a lot of it was more fun for people to try to, you know, support this and make it more aware. As far as the length of time for the benefit, you know, I don't really know that answer, in as much that I do know that it really doesn't have a whole lot of benefit. I mean, it's going to increase your lifespan by 2 to 3 months, 3 to 4 months, and that's all. So really, like I said, I would classify kind of like with medications for Alzheimer's, where there's really not a whole lot of benefit with this medication. I mean, it can increase your life for 3 to 4 months, but are you really going to be increasing a life that has a high quality of life is the real question. And it really doesn't help a lot of those symptoms that you experience with difficulty swallowing, with weakness. It doesn't really reverse those symptoms. It slows the progression minimally, but it still progresses.
Okay. James wants to know what the length of time when Botox is used for excessive salivation.
So the length of time, as far as how often it needs to be done, because a lot of times it needs to be done like every 3 months. Typically, it happens pretty rapidly after injection. It's not something that takes a whole lot of time where it needs to build up or anything like that. I don't know the exact length of time. I would say it would be pretty rapid. I didn't actually look up to see how quickly it happens, but I do know it's relatively quickly.
Are you able to see the chat now?
Yes.
Okay.
Yeah.
I'll let you just...
Okay. As far as the type of opioids, a lot of times what they're going to use, what I've seen is like Roxanol or liquid opioids, because these patients have difficulty swallowing. They really don't like to give pills in patients like that. So typically liquid options are the best. Now you always can do PR or rectally, but that's not as used as often as I would have assumed as in hospice, as from what I've seen so far. I think that's I don't think people like getting administered it that way, especially if they're at a home. I don't think necessarily family members like administering it. So if there is other options that are able to be given, such as liquids by mouth, they still are able to swallow liquids, I would say. Liquid opioids are going to be what I have seen in the patients with hospice. So as far as what I see, a lot of times as far as that, it's going to be hyoscamine or Levsin or the Robenal. The scopolamine patches are really good. The problem with those is they're expensive. And with us, we're a not-for-profit hospice organization, so we try to use agents that we can to the best of the ability. Typically what I see is Levsin or hyoscamine, and then the glycopyrrolate is what we typically use.
What do you guys use, Leah?
Inpatient, we tend to use a lot of IV glycopyrrolate. Usually start out at every 4 hours. Do you use it more frequently than that?
Typically, yes. I don't know the exact frequency off the top of my head about how often we use it, but I would think, because we don't do IV typically in hospital, it's typically PO. Yeah, we do use atropine eye drops as well.
You know, one of the things I thought was really interesting around the atropine eye drops is when we did our DUE for the hospice, for Hospice of Southern Illinois Drugs, I found that there were probably a quarter of the prescriptions that came through to be covered were billed as the more expensive name brand ones versus the generic. Do you guys see that in your hospice organizations where it's because we use a PBM. I can't remember the name of the PBM we use, but you know, we have a benefit manager that contracts with our pharmacies, and I wonder why they're letting some of that stuff go through, or if that's stuff that we can jump on as pharmacists.
Outcomes resource is what we use for our PBM, which determines all our pricing of our medications here at HSI.
So, loss of function in any certain order.
So like it's typically, it starts as unilateral. So it's usually one leg, one arm, one finger, not one finger, but one hand. And it slowly progresses. As far as the order, it's patient specific. There's no typical order that it kind of goes, but it does progress. So if it could start with weakness in your hands and having difficulty talking and breathing and swallowing as well. There hasn't been really any consensus of the specific order of how these events happen. It's really patient specific from what I've understood.
So when you were spending some time looking through the materials for this, did anything jump out at you as far as a area that pharmacists trained in pain or palliative care would really have an impact with these patients?
I mean, I think the biggest area is just symptom management. And that's really all these patients can get right now. So I would say knowing the drugs, knowing what drugs you can use for secretions, knowing what drugs you can use for constipation if you're having to use a TCA for secretions, knowing what drugs you can use for spasticity as far as what has been studied, like baclofen and tizanidine. Really, it's going to be symptomatic treatment with medications that we have our biggest role, in my opinion.
Okay. Have you seen that one of the muscle relaxants is more favored on your different hospice teams there than others? Are they?
Honestly, I haven't seen a whole lot of muscle relaxants used. It's been very few that have actually been used. Now, the ones that have been used, I've seen baclofen used a couple times. I've seen no Flexeril yet.
Good.
And I actually haven't seen tizanidine either. So really the only one I've seen is baclofen, but it's pretty rare that a patient would be on that, from what I've seen.
Very cool. Any other questions or comments? What do you guys,
And I know that sometimes ALS and dementia do go hand in hand. And I mean, like I said earlier, there have been clusters that have been found in different areas, and they really don't have a good reason as to why that's happening. I mean, I know there's a bunch of different studies out there that it's in the water, or it's in things that we eat or drink, but we really don't know why these clusters happen and why there's different clusters of ALS when other places don't have them. So that is very frightening that that is happening, the aggressive dementia with ALS together.
that seems like that could be a problem too, because you're basically the treatments are opposing, right? You're going with cholinergics and anticholinergics.
Yeah.
I don't know.
Yeah, that's
Bad news. Well,
very bad.
Anybody, are you guys able to unmute yourselves, or have I muted you? Michelle, you're not muted. Are you able to talk?
Can you hear me?
Yeah, I just wanted to make sure that this would work.
Yeah, I actually couldn't find where to mute and unmute myself until just now. So I did not know I wasn't muted.
Okay. What do you all think? Is this a viable vehicle for doing this? Was it pretty easy to get on, and were you able to, did anyone have problems or have problems with seeing the slides or hearing Brad or anything like that? Did we look at other delivery vehicles, or is the Zoom okay? It was great. All right.
Good.
Well, what I would say is tune in next week. I agree. Great job, Brad. Tune in next week at 10 a.m. I haven't figured out how we're going to pull this off yet as far as scheduling and getting the topics and stuff out to everybody. I may talk to the SPCP people about housing it with them, or we might just house them on a shared folder. What we can do is we can try to come up with a master schedule so that if other people are interested in having their trainees present or participate, we can maybe give Brad a break. Okay. But You know, that's what you get for signing up to be the first, right?
Hey, it's okay. Yeah, I'm okay with it.
But I agree, Brad. You did a great job. Thanks for being our very first presenter. And until somebody volunteers, our only presenter, maybe I'll take one of them 1 week to give you a break.
Okay.
Last question. Are there practice guidelines for ALS? And if there are that you saw, do they specifically discuss the palliative management of ALS patients in them?
So there are some guidelines. The American Academy of Neurology put out guidelines for symptom management, cognitive behavior control, and different aspects of it. However, at least the ones that I found were from 2009, so they're somewhat dated. Some of the information in there I found is outdated. They say there's not data with TCAs and some other things when there has been data that has come about since then. So I did find some guidelines. However, from what I found, most of it was somewhat dated.
Okay. All right. Anybody else? Well, it looks like at least the folks that tuned in are drinking the Kool-Aid. They liked it.
Good. It was fun.
All right. You all have a great weekend, everyone. Thanks again. And special thanks to you, Brad, for doing this. I thought you did a great job. I learned a lot. And I think this is a good way for all of us to get together and make sure we're all continuing the process of lifelong learning. So thanks, and everyone have a wonderful weekend.
And thank you guys for showing up. Appreciate it.